Eye Health. And Dr. Namrata is right now not here, so I will request Dr. Harpreet to chair the session with us. And I also request her to give a brief introduction about the session.
Thank you, Dr. Praveen. So, yeah, so I'm glad we could all, at least some of us, are here for this particular session. And as always, unfortunately, this session gets excluded and it's pushed towards the end. And we usually kind of, try, not the Vision 2020 session, but when we are, I'm talking about inclusion particularly. So, but anyway, glad at least some of us are here. So, anyway, not wasting too much of your time, and I think we'd like to stick to the time slot we have. And I would like to invite Dr. Rohit Khanna from LVP to give his talk on 2030 Agenda, Leave No One Behind. Dr. Rohit, thank you.
Yeah, is it audible now? Yeah. So I'll be just giving you 2030. So 2020 is over, and now what next? So every time it's like 2030, then 2050. So it's an ongoing thing. So it's going on for ages. So now we have next 2030, and we need to come with something, package something differently. The same wine we have to put in a different bottle and package it differently so that it is more sellable, and we can get more funds and we can carry on our programs. So I think these are the facts everybody knows, at least those sitting in the room, that the, the World Report on Vision came up with the fact that everybody in this world will require some kind of eye care, and at least 1/3 of the population in the world will require experience eye care, will need eye care services during their lifetime. And so eye care is not only about eye care, but it also have impact on many multiple things. So I think the Lancet Commission again came up with this fact that at least 90% of the visual impairment are in low and middle income countries, and improve eye health can also improve the economy in terms of like productivity and all that. So it can affect sustainable development goals. It can improve educational performance, it can improve mental health, it can improve well-being, and so on. So there are multiple like lateral effects of eye health, and we just talking about like what we talk about, like we don't market ourselves so well. Like we say that eye care, we did cataract surgery, we did this surgery, and vision came 6/6. So my outcome. So we just focus on that. A narrow area of focus is like I did surgery and what's the vision, but what's beyond vision? How does it impact the person's life? I think we don't look beyond that. So we don't get a holistic picture of this. For example, you look at like road traffic accident. How many drivers had a vision problem? Had they not had a vision problem, how many accidents could have been averted? So many things, so many things. And despite that, like if you look at last 20 years, thanks to efforts for Vision 2020 and program where IPB and WHO came together. IPB stands for Internal Agency for Prevention of Blindness, and World Health Organization came together in '99 and launched the initiative called Vision 2020, which I think gave accelerated eye care advocacy for eye care across the globe, and or we also could do in India. And there are a lot of success stories happened, like we could take care of like trachoma, onchocerciasis. We developed multiple models of eye care delivery, and then we had a lot of advances in technology in terms of cameras and all that. So there's a lot of achievement we got in last 2 decades, but I think there is a lot more to achieve now. And what happened is after that is like multiple World Health resolutions. So we were all in the UN General Assembly. Eye care was on the top agenda, and recently they also put eye care as a model where eye care will be required to achieve, like if you want to achieve your goals of sustainable development goals, you cannot exclude eye care. Eye care is very, very important to achieve your target of sustainable development goals. And these are the key documents which came recently in last 2-3 years. World Report on Vision, which came in 1990, which gave the foundation of like what's the magnitude of the problem and how should we go ahead. And the Lancet Commission came up with what happened in past 20 years and what we are going to do in next. And then the biggest thing which came is the World Health Assembly resolution, which was passed last year in May 2020, where they said that without eye care having included in as a part of universal health coverage or in the SDG agenda, we cannot achieve the SDG goals. We had all these issues. There are certain issues which I will just touch upon, and these are like not new issues, but these are like issues for decades. But I think the magnitude keep on changing, and one major thing is like the eye care is also looked at more of a vertical program, but it's always a question of debate whether it is vertical is better or horizontal is better. To some extent, we have to be vertical. We cannot like say that we will be integrating at all levels. So we have to find areas of integration where we can synergize with other specialties or other sectors, and we have to find areas where we have to just do in our own work. For example, cataract surgery. You need a cataract surgeon only to do a cataract surgery, but you require a physician and all to at least do investigations and all. And then if you find diabetes, then you can send them for other diabetes examination. And also, there is a level of integration, like what happens at primary level where you can integrate secondary level, tertiary level. So what is the limit of integration, and at what levels how much should we integrate, and what are the benefits and what are the reciprocal benefits to eye care as well as benefits to other sector. If we just say benefits to eye care, and we become very selfish, so nobody is going to come forward. So unless we sit across and have a dialogue that this is the benefit we have across each other. For example, Mohan Diabetes, they do eye care, they do diabetes also. So there are like good examples of integration, like ROP programs. It's again another good example of where we have to integrate. But I think more or less we have been running it very, very vertically. And the other thing is like lack of coordination with the private sector. If you look at private sector has a major role to play. For example, private ophthalmologists, we ignore them completely. I think look at this session, like how many people are more, very few people are there. Most of the private ophthalmologists don't even know about what's going on in this forum actually. So I think we need to advocate more at this AI All India sessions and all that for eye care. And second thing is like, for example, industries, like for optical industries, one of the major industry, which is like refractive error is a major problem. So unless we talk to this industry, you cannot solve unless the industry, how did trachoma got control? How did Onco got control? It is like the UN agencies, it was more of a bilateral partnership between different agencies, pharmaceutical companies, private sector, not-for-profit sector, non-eye care sector, they all came together. So it was a multi-level partnership, and that is what had led to success of that program. So something like that we have to do for refractive error, and refractive error is not like Onco or trachoma where one-time solution is there. Every year, at least every 2 years, we have to change a pair of glass. So how do we do that? So another thing is like our HR. So it's so unregulated. We have only recognition for ophthalmologists. Even optometry is not very well recognized in this country. Forget about AOP. We don't even have a accreditation for this AOP. And it's not only in India, but many countries have the same story actually. And eye care is also not part of information health system. So we have a separate district blindness control society. We have a TB program going on vertical. We have a leprosy program going on. So we have put in the vertical baskets all these programs, and we are running them parallelly. So what do we need to do is like these are the couple of strategies we thought of, like we have to overcome like the lack of awareness, funding issues, then move from vertical to horizontal programs, and then also create regulatory framework for our optical deliveries. And I won't go into details of that because this is more of a strategy kind of thing. And this is what the World Report on Vision came up with, like make eye care an integral part of universal health. That means eye care should be part of universal health, and implement integrated people-centered eye care. So this integrated people-centered eye care, they're talking about integration. But what is integration? At what levels you should integrate? How much you should integrate? What are the reciprocal benefits? I think that has to be very, very clearly laid down. Otherwise, we keep talking about it for another decade and then nothing will happen. Another area is research, and then also we have the only indicator we monitor is like number of cataract surgeries. And even last year we are not getting the number of cataract surgeries which were done in binational program for control of blindness. So even that numbers become difficult. So forget about the aggregated data by gender and other things. So we hardly have data in terms of like cataract surgery output. Forget about outcome and impact indicators. So we need to have systems in place where this indicators or these output indicators are generated automatically. I spoke about this World Health Assembly resolution which was passed recently last year, and also I talk about Sustainable Development Goal. The goal 3 is, which is very, very highlighted, that eye care impact directly the goal 3, which is ensure healthy lives and promote well-being. But if you look at direct and indirect impact, there are multiple ways eye care impact different SDGs. So these are direct and indirect impacts of eye care on different SDGs, and there are a lot of evidences on that, and for some SDGs we are also generating evidences. I spoke about this, and to this recommendations, also WHO recently came up with packages of eye care interventions, and this eye care guide for action, which was launched recently on 24th May 2022, the eye care guide for action gives you the entire gamut for what all should we do in order to implement IPEC, how should we go about implementing IPEC. If you look at the guide for action, it includes everything in terms of monitoring, in terms of implementing IPEC. I won't go into details of that, and IPEC I will skip. And these are the elements which are required to implement again IPEC. This is all related to IPEC. I will skip over this, and this is which targets. So these are the only two major targets WHO is going to monitor of cataract surgical coverage and refractive error coverage, which is effective cataract surgical coverage and effective refractive error coverage. I won't go into details of the definition, but you can look into it. But these are the two indicators which are used by WHO to monitor the progress of eye care in terms of achieving universal eye health as well as impact on SDGs. And the eye care guide for action give you all the tools. Please go through it. This has been launched a week back, only 2 weeks back, and it will give you all the tools, how you can plan, how can you implement, how can you monitor, and how can you report also. And these are some of the milestones which we had laid down at the IAPB headquarters when we had a planning meeting. And I won't go into details of these milestones. And these are the areas which we had 10-point agendas, 10 priorities areas which will impact SDGs. But ultimately, goal is to monitor two indicators, which is cataract and refractive error. I think if we do these two properly, I think this decade, we have achieved a lot actually. Thank you.
Thank you, Dr. Rohit, for this comprehensive providing comprehensive details about eye care services and of course leaving no one behind. I believe the key issues are universal eye health coverage everywhere globally and attaining SDGs through the system. Thank you very much. Thank you. Now I request Dr. Harpreet Kapoor. Dr. Harpreet Kapoor is Regional Inclusive Eye Health Advisor for Asia for CBM, and she'll be talking about inclusive eye care, addressing barriers to access. Dr. Harpreet Kapoor.
Okay. Yeah. Thank you, Dr. Praveen, and a very good afternoon to all. So I'll dwell a bit deeper into the measures which we need to take to ensure that our eye health programs are inclusive. So just to set the stage, I would like to draw your attention to this very common scenario which we come across in our eye health practice. It's a bilateral cataract, as you see, and we spend hours deliberate in conferences. We've spent 4 days here and across the world. We try to come up with newer techniques so as to give 6x6 or eagle vision to our patients suffering from cataract, and ensuring that they can enjoy the best of the quality of life and enriching quality of life which they deserve. But yet another scenario when we come across, like this patient had retinitis pigmentosa and was left with 1/60 vision, and the normal usual response would be, sorry, nothing can be done for you. Well, this statement in itself can be really devastating for a person who's come to an eye care organization to get some extra vision or to enjoy a decent quality of life. So this is what inclusion is all about. It is, we need to ensure that people with all kinds of disabilities, they benefit as much from an eye care service as any other individual. So a person might come to you with low vision, blindness, or a person with a physical disability, hearing impairment, or intellectually challenged people as well. So this is all about strengthening eye care services. This is what inclusion is all about. No rocket science there. Just we need to take some baby steps to ensure that our services do cater to people with all kinds of disabilities. I'm sure everybody is familiar with this pictorial representation of global burden of blindness, which came out in the World Report of Vision. And as you know, the staggering figures there are about 2.2 billion people, which is 1/3 of the world's population, which suffers with some kind of visual impairment or blindness. And unfortunately, it is about 1 billion of these people who do not have access to quality eye care services. And then the most vulnerable populations there do suffer, and they are kind of marginalized extremely when it comes to eye health services. Just to dwell a bit deeper into some of the key points which came out of the World Report of Vision, published in October 2019 by WHO. So as I already said, there are 2.2 million who have visual impairment, and in 1 billion it is not addressed. Majority of these belong to marginalized groups like people with disability, women, elderly, ethnic minorities, and indigenous groups. And another figure which I would like to draw your attention to is that there is around 15% of the global population has a disability. And interestingly, almost everyone is likely to experience some form of disability, temporary or permanent, at some point of life. Okay, so how do we ensure that our services, any eye care service, is inclusive? The first step is to identify the barriers which exist, not only for people with physical disability, but all kinds of disability. That's hearing, people are intellectually challenged, and then, of course, people suffering with low vision or blindness there. Okay, so some of the common barriers to access are communication, first of all, physical access, which most of us are familiar with, then availability of services, low vision services, those are majorly lacking. People are not interested, organizations are not interested in developing these, mostly because they are not really profitable. Counseling services, then affordability is an issue. With most of the people with disability, we've seen that poverty and disability go hand in hand, and there are some extra efforts would be required by organizations to ensure that specialized services are available to people with disability. And then attitudinal. This, although listed last, but I would say it is one of the key ones wherein, so if there's a change, if we can address this part, all the other things listed above can be taken care of. So attitudinal change is one key important area which we need to look into. I would just
My
like
name is
to...
Ed Wilson, and I'm here to talk to you
Yeah.
about communicating with patients who have disabilities. Now, my first bit of advice is to talk to the patient. Don't make assumptions about what they can do and what they can't do, and realize that a patient with a disability still has many other abilities, and they have their own story, so try to involve them in their own care. Ask first before communicating with a caregiver, and use people-first language. It's a man with Down syndrome. It's a child with cerebral palsy. It's a man or a woman who uses a wheelchair, not someone who's confined to a wheelchair, or a handicapped man, or just be respectful and speak to them. Treat adults like adults.
Yeah, so that was a very short clip shared by Ed, which very nicely kind of, gives us the sense, gives us the message that when we communicate with people with disability, we need to talk to them. Often, like if you come think about a scenario when you are treating a patient, usually if there's a caregiver or a person attending the person with disability, say a person is on a wheelchair, you inadvertently or at a subconscious level, you start talking to the person who's attending the person with disability, the person who's on a wheelchair, and so not talking to that person directly. So we do need to realize that. So the person has a physical impairment, but intellectually he might be, way better than most of us sitting here even. So then one of the common things which come across to our mind when we talk about addressing barriers or disability, making services inclusive, are these ramps and railings. Of course, this is a must, and this is one of the first steps wherein, obviously it is resource intensive, but wherever possible, you can kind of ensure that ramps and railings are there, wide doorways, tactile flooring. So this is just one of the example of Kumudini Hospital down there in Bangladesh, which was CBM supported, and the whole building came up with ensuring that all the infrastructure is accessible there. And these are examples from our CBM supported hospitals in Cambodia and Indonesia, wherein they have these high contrast floor markings, which is easy for wayfinding, especially for patients with low vision. Then, of course, low vision services, one of the most unfashionable and services which organizations are not interested in developing. So this is, of course, because one of the reasons is they are not profitable. And but we are happy that CBM has been able to support several centers in developing their low vision and rehab services. And very recently we were at RP Center, and so happy to see the low vision and rehab services come up so well. In fact, they have also supported development of these services at 16 RIOs, and next 3 years again there's a program in the pipeline which which will take this to the next level and ensure low vision rehab services come up in other aims as well. And then, of course, we have examples at Joseph Eye Hospital, Trichy, and this one is from Zambia, Kitwe Eye Hospital. And one of the another important areas of developing inclusive services are counseling services. So we all very well understand that, ophthalmologists are busy people, so obviously they wouldn't have enough time to give to each and every patient, to explain to people, suffering, especially from intellectual disabilities. Sometimes you might get a child with Down syndrome and having cataract, but then you might just leave it to a junior colleague or send the patient elsewhere because you might not have time and might also think that, okay, I can do 5 phacos and the time I would spend in getting things across to this patient. So here the importance of counseling services lies, because any person with disability who comes to you can be referred to a focal point, a counselor. And the counselor who's doing counseling for you for your phaco packages and all can be trained. And then that person can give enough time to ensure that the person is referred to the right service, a person who has a hearing impairment. Documents can be shown as to, whatever the services are available. So we have a focal point in your organization to ensure that all people with disability are guided there. And they do make the best use of, the services available at your organization. And like I said, last but not the least, attitudinal change is the one which is absolutely essential to develop inclusive services. You can start off with having sensitization workshops at your organization. Employment, this is one picture from the Lahan Eye Hospital, the Biratnagar component of it, wherein the optical unit is giving a lot of revenue to the organization there. And it is, you can see the chief optician is on a wheelchair. And I would say employing a person with disability is one of the most powerful ways of ensuring that we think ability and not disability. Thank you. Thanks for your patience.
Thank you. Arpriti, I think there is no lack of knowledge about the problem. And there is sporadic efforts is being made to solve this problem. So what I feel, we have to develop a comprehensive organization sort of thing which can plan a cohesive approach to solving the problem. I think AIOS can play a big role in this, because we are doing a lot of charitable work and here, but they are all spread out and the effect is not visible that way.
I think the impact is not there. Everybody is doing it,
So,
little bit, but it's not kind of consolidated or
yeah.
it's not
I think a
cumulative.
long-term plan can be done because
Yeah.
presidency may change, but the AIOS can take a
Can change.
long-term thing,
Yes.
and this will be a very effective because
Yes.
a lot of work is being done in solving, but the effect is not shown to the
Showing.
outside.
Yes.
We are so
Yep.
glad you kind
I
of touched upon this, and we are actually thankful to Dr. Namrata. She spared time to be to chair this session, and we really would appreciate if this is adopted by AIOS. Then only we can have a larger impact. And like he very rightly said, the sporadic attempts are there, but if AIOS adopts it,
Yeah.
it'll be great.
I think
So thank
she
you,
is
yeah,
the right
Dr.
person.
Namrata.
She is
No, surely.
incoming president, so
Surely.
Yeah.
so
Okay.
she will have a long innings. So she will do this. I invite Dr. Praveen Vasist, the Chief of Community in RP Center, a very dynamic person, and he is going to talk on this advocacy for integrated inclusive eye health.
Thank you very much, sir. In fact, I'm talking about advocacy for inclusive eye health. And probably this session itself an advocacy that Professor Namrata Sharma is here and Dr. Amalya Sahu has raised an issue that some kind of organization should be there to look after this system, and AIOS can take lead into this thing. Probably we can understand this is actually advocacy. In fact, when you talk about inclusive eye health, we mean that eye health services that are provided within a barrier-free environment. In fact, Dr. Harpreet has mentioned about all the barriers, and they should be inclusive by design, and also sustainability is important point that they should be sustainable. And to ensure that eye care services should be accessible and inclusive for people with disability. With disability as well as, of course, with people without disabilities also. So for everyone, it should be comprehensive. And we should ensure that those with permanent vision loss, they should also be provided with facilities like rehabilitation, orientation mobility, living skills, educational rehabilitation, and also livelihood. So whatever if we identify the target group, which actually are vulnerable group, they're the people with disabilities, and they are the largest minority group in the world. There's a vicious cycle between poverty and disability. People with disability constitute 20% of the world poorest population. And at least 20% of people with disability, they cannot regain their eyesight. So they are also suffering in that area also. The other vulnerable group are women with children, elderly, illiterate, people living in rural areas, tribal areas, urban slums, and people with below poverty line. When you talk of advocacy, it's advocacy for leaving no one behind. That people, they have the human right, and the people with disability and vulnerable group, they actually should be protected through the right policies. So human right through laws, probably this is one area which probably easy to achieve. In 1995, we have People with Disability Act. It was revised in 2016. So policy domain as well as law is already available with us. The second group is the equality of opportunity. Dr. Harpreet has clearly given details about all the barriers, whether physical barriers, whether it is financial barriers, communication, attitudinal barriers. Probably all these is a slow process. This will take time. The government of India, they have taken some steps in this area, and we are hoping that in future this problem will be resolved and will be much better. And third is the stigma and discrimination, which is probably further long time. We need long time for that. It's a society change, and that also will be a processual change. If we this is a commonly used diagram for differentiate between equality, equity, and inclusion. When we have a barrier and we give equal support to everyone, this is equality. This is definitely not good because the person with shorter height is not able to see this match. Equity means we are giving a support so that all of them are equal. They can see match, but when we talk about inclusion, the barrier which is there, that should be removed. That is the ideal thing, what we need for inclusion. As far as Vision 2020 Right to Sight concern, we have come with a strategic plan 2021-26, and the key objectives are, of course, giving emphasis on universal coverage, including community, ASHA workers, school vision screening program, a consolidation program where we are looking forward so that a district level model can be developed using primary eye care or vision center approach and people-centric approach. Then you should use technology, we should use awareness, behavior change models that is systematized, coordination between central government, state governments, and even up to district level, and of course the advocacy for all these things. Vision 2020 says that when we do advocacy, that advocacy should be emphasis on collective evidence-based advocacy. This is very important. We need to generate evidence first, then we have a solid proof, then we should go for advocacy towards even our partners, towards government or other stakeholders. So as far as evidence is concerned, I'm just giving you one just slide. These are the indicators related to sustainable development goals. And you can see that there is clearly lack of disability segregated data in our country. Just one indicator, the percentage of person with disabilities having unmet need for assistive technology. That has been provided because RP Center recently conducted RATA, Rapid Assistive Technology Assessment Surveys. That's why we have this indicator for people with disability. As far as all other indicators are concerned, there is no data available in country. Recently, Government of Communication, the Ministry of Communication, they have given these guidelines to all the ministries that segregated data related to disability should be generated in the country. So this is one step. Of course, it is related to some advocacy only. And I'm giving one example. The data related to person with disabilities completed at least secondary education with age 15 and above. This information has been recently provided by Niti Aayog, that this information is there, that people of disability, what proportion of them are educated. It is highest in Delhi and it is just 41%. In Delhi, the education enrollment is nearly 100%, but just compare the people with disability, 41% are educated. And in Northeast, just hardly 10% people are educated. This is the gap in our country, and probably we need to fill this gap. So for advocacy is concerned, we need to do advocacy at various levels. That is at policy level, that is the highest level. We need to create an inclusion task force. In fact, recently, sir has just mentioned there should be a group or organization, probably a national level task force is needed as part of National Program for Control of Blindness. I'm very sorry to say that even at this stage, our program was started in 1976, and even at this stage, there is no word inclusion in National Program for Control of Blindness. Even in our strategic plan, I'm part of Vision 2020, I'm representing a vice president. I've seen the entire document yesterday. The inclusion component has not been added in strategic plan of Vision 2020. Dr. Frendra, I think we need to revise it slightly. Then advocacy at the organization level where the staff need to be trained, service delivery, comprehensive level, at PSC level, vision center level, district rehabilitation centers, at all level we need to do advocacy, and at community level for ASHA workers and other programs. So there have been some advocacy initiative at national level also. What we plan to do is that there should be national focus on inclusive eye health, and the things are easy to write and probably are very difficult to implement in our country. So we are hoping that these initiatives should be taken care of the government in near future. That is national focus on inclusive eye health, health eye care services accessible to all, especially for those with physically disabled, integration of government system and government ownership. We show different models, best practice model. Probably they should be taken care by the government in future, and the facility should be available in all part of the country. Community awareness and change in their perception is extremely important for inclusive eye health. And a sustainable referral system. The people with disabled people, they should be referred to right place. That is also need. In fact, when we talk about the National Action Plan, in 2015, RP Center conducted this workshop where all the stakeholders are invited to develop this National Action Plan. And we planned that we should have facilities at all the levels. And I'm sorry to say that even at this stage, even regional institute of ophthalmology, they don't have low vision clinic. Forget about the other lower level, the secondary level or tertiary level institutes. In fact, the key issues which I would like to share here is that some of the initiative taken by RP Center for low vision rehabilitation and inclusion. One is, the best part is that we have enrolled nearly 75 NGOs in Delhi who are working for low vision rehabilitation. In fact, it's a very good mutual partnership. RP Center is providing low vision services, clinical services, and these all organizations to provide rehabilitation services. So both of us are using taking benefit of each other, and currently 76 organizations are attached with us. Primary eye care services. I think Dr. Khanna has just mentioned that for achieving a universal health coverage, Vision Center of Primary Eye Care services are essential. RP Center has developed 27 vision centers, and they are being now sustained with the support of Christopher Blind Mission. Plus, in School for Blind, in fact, with the WHO CRO supports, we have got a pilot project in which we are providing inclusive services, even assistive technology, in 2 schools for the blind, and in future we plan to take 35 such schools under a program with Christopher Blind Mission. Assistive technology is also very important. We need to provide assistive technology. As I mentioned, we did RATA survey. As per this RATA survey, nearly 50% of the disabled, they are not having access to assistive technology. That is the need of, in general population, 92% has coverage, but in disabled, only 50% people have assistive technology coverage. I just want to give one good example of advocacy where Ministry of Social Justice and Empowerment, Social Justice and Empowerment, they develop a committee, and this is a card actually which is used for certification of disabled. Previously it was very difficult. Even doctors, they used to come to us to give the percentage of disability in any individuals. Now using this matrix, even a lay person, if they are aware of the best corrected visual acuity in both eyes, they can easily get the percentage disability in them. So this is one area where we are able to at least help different organizations, even the patient, that they should know actual percentage of disability. Then the last thing which I would like to share, that we are planning to have a national task force on inclusion in eye health. The key objective is to provide leadership to National Program for Control of Blindness, Ministry of Health, for strengthening inclusive practices in eye health. So there are certain terms and conditions which I have mentioned here. I'm not going into details because there is lack of time. But of course, we already had a meeting with Health Ministry, and we plan to have a national level task force very soon. Next month, we are planning to hold a meeting in RP Center in relation to this. And we believe that the Ministry of Health, the NPCB, the Joint Secretary and Deputy Director can be the chair and co-chair for this. We have involvement of All India Ophthalmic Society, representative of other ministries, RP Center, Vision 2020, other organization working eye care, all can be the stakeholder for this task force. I think in the end I would like to say that we need to empower people with disabilities with equal opportunities, protection of right, and full participation. Thank you very much.
Thank you. Yeah. See, 2 points I want to mention here. See, when we are dealing with the government, we say that if the government is a wise body. It is actually it is not a wise body. That is, the ministers don't know anything about any health, and particularly eye, they hardly any understands. So when we are interacting with them, and the bureaucrats come in between, and then they show their power. To overcome that, if you are going in a fractional way, we cannot match them. So there has to be, as I told earlier, Namrata ji, we have to have representative from all institutions. Otherwise, what happen? The institution wants to take over the responsibility of doing things, the other people fall out. That should not happen. You select representative and form an ombudsman. And then the minister has to be given a talk. Those and a lot of people are, and the bureaucrat also has to be confronted, and then media must be managed. So the media is a big thing. We are meeting the minister is not listening to us. So that kind of thing will scare them. If you go hanji hunji karo, they are not going to do anything, and your time will be wasted. Somewhere we have to develop that.
Sir, I'm not talking about the health minister, I'm talking about ministry which is being represented by a Deputy Director General who is taking care of the program itself. He is just concerned with the eye care program, and one joint secretary level person who is managing this program only. They listen to us, they need us, they listen to us also. We don't need to go to health minister directly. It is the deputy directorate level people who are managing this program. We have to do advocacy with them, sir. And of course, when all other stakeholders, AIOS, Vision 2020 and organization, they are part of it, I believe we can definitely
Yeah, that
achieve
is
things, sir.
the, let us work out for a permanent solution to this thing, sir. Thank you.
You want me to close?
Yeah, our next speaker is Mrs. Sampada Savade, Director, Parkins India. She is going to talk on establishing inclusive eye services, our experience.
As an extension to all the eminent speakers talking about inclusive health services, my presentation will focus on children with multiple disabilities and vision impairment. So before we begin, just to share a background or to set the stage, who are these children with multiple disabilities and vision impairment that we are talking about, or we are going to be hearing about in this presentation? The first photograph on the slide is of a child who is totally blind, and he also has a hearing impairment, what we also commonly refer to as deaf blindness. The second child on the slide in the yellow t-shirt has low vision, and he also has a physical impairment or cerebral palsy. And he's trying to grab the yellow toy that his father is trying to show him. The third photograph is of a child who has again cerebral palsy, vision impairment, and an intellectual disability. And she's with her mother trying to explore a tactile and light-based toy. And the last photograph on the slide, where you see the student with her teacher, is again of a student who has low vision, cerebral palsy, and an intellectual disability. So when we are talking about children with multiple disabilities and vision impairment, these are all the children that we will be referring to. Meet Rihan. In order to identify all these children with multiple disabilities and vision impairment in the community, our team in different states, currently we are in the state of Uttar Pradesh, do a lot of screening activities in the community. All these screenings would be through door-to-door, screening in regular schools, screening through village camps, with the collaboration of civil hospitals. And through all these screenings, we have identified several children like Rihan. So when we first visited Rihan at his house, the first complaint or concern that his family had was that Rihan doesn't use his vision at all to do anything. All he did was use his sense of touch. Because Rihan also has a profound hearing impairment along with his vision impairment. In collaboration with eye hospitals like the Sitapur Eye Hospital or Dr. Shroff's Charity Eye Hospital, Rihan fortunately received a proper clinical assessment. He received a pair of spectacles. And after that, today, Rihan does a lot of activities where he uses his vision very effectively. Right from pre-reading, writing, coloring to participating in games. And it has made a world of difference for children like Rihan. And special mention to hospitals like Sitapur Eye Hospital or Dr. Shroff Charity Eye Hospital, even L.V. Prasad's Eye Institute, with whom we have collaborated earlier. Because assessing these children can take multiple times for assessment. It's not a simple process, but the patience which the vision technicians and ophthalmologists have had have made it a lot easier for several children like Rihan. In addition to the clinical assessment part, our team of special educators also does a thorough functional vision assessment of the children to ensure that when we plan an educational program for them, all the children have the adaptations that they require to use their vision very effectively beyond having a spectacle or a low vision device. We realized that just doing the clinical vision assessment part and providing a child a pair of spectacles or a low vision device and letting parents know how he should use his spectacles is not enough. Because when we are talking about children with multiple disabilities and vision impairment, they require a lot of intensive intervention. And for this reason, we have set up intervention centers at both the hospitals, at Dr. Shroff's hospital at Vrindavan and at the Sitapur Eye Hospital. And our dedicated team of educators, vision therapists, physiotherapists ensure that all these children don't just stop at the clinical vision assessment, but go on to receive comprehensive educational rehabilitation. Several children with vision impairment and cerebral palsy who require therapeutic intervention, we ensure that they do have the access to that at the center. Several children require assistive devices. It could be a wheelchair, it could be a chair for cerebral palsy, it could be a walker, anything and everything that the child requires to use his vision and most importantly, to learn. They learn several new skills at the center apart from learning to use their vision. It could be skills in the area of cognition, socialization skills, using their hands or motor skills. It's a range of skills that they learn along with each other, supported by the educators and parents. Dr. Namrata, Dr. Praveen mentioned a lot of barriers for children to having access to services, whether educational or health services. A big factor is affordability and physical access to the center, specifically for children who belong to the below poverty line economic group. For them, to ensure that no child who needs intervention is left behind. If a child can't access the intervention center at the hospital, we use the community-based approach to ensure that the child receives intervention at home. The most crucial component in this entire process of intervention is the parents. And parents receive regular training. If you look at this photograph of children sitting at the intervention center at the hospital, you see a group of children with special educators as well as their parents. So all along, it's about transferring skills to the parents as well. Because at the end of the day, we are also thinking about how to make this model sustainable so that it lasts forever and children continue on their journey of learning. It doesn't stop with us. So at every step, whether it is intervention at the center, at home, in the community, parents are always along with the special educators, learning all those skills and following up on all that they learn in the home setup as well. Till date, we have been able to screen more than 3,500 children. All of these who require the vision intervention, we ensure that they have received the vision intervention, surgery, spectacles, and beyond that, more than 300 children with multiple disabilities and vision impairment are receiving intensive educational intervention. Of course, considering the magnitude of the problem, this is just a beginning, and we have a long way to go. So, thank you.
Our next speaker is Sabitra Kundu. He is going to talk on gender equity and eye health.
Good afternoon, everyone. Following all the eminent speakers, Dr. Rohit, Dr. Harpreet, Sampada, and all the others who have spoken and have spoken about inclusion, have spoken about the need to take everyone and leave no one behind, I would like to touch base upon gender equity and eye health. When we talk of leaving no one behind or inclusion for everyone, we as Dr. Rohit during his presentation or Dr. Praveen during his presentation spoke about all the seminal studies that have been done and have spoken about. Also touched base upon that women and other genders are also a neglected group and a group that needs to be focused on as we take our work forward. Just setting the context, we all know these statistics that at least 2.2 billion people have vision impairment, which is 14% of the world's population. And it's also a documented fact that there are more women with vision loss in every category of vision impairment and blindness. 55% of all people with vision loss are women and girls. And of the 1.1 billion people with vision loss, 55%, that's 609 million, a staggering number, as compared to 497 million are women. Overall, we also know that women are 12% more likely to have vision loss than men. But what is also significant is that visual impairment leads to loss of jobs and productivity, and it increases the dependence on other family members. Women, they're often neglected, they're the caregivers, they're the homemakers, they're left to fend for themselves, and their potential and their freedom are limited to a large extent. And this is seen across, whether it's the developed countries where people live longer, or in the lower and middle income countries where, because of lack of access to service and lack of availability and affordability of services, women are also marginalized and also suffer. Dr. Rohit has been part of this seminal study, the Lancet Global Health Commission on Global Eye Health, and he's also alluded to it, as is Dr. Praveen. And some of the key findings from this speaks about that in some settings, the higher rates of vision loss experienced are more in women, and it is socially determined. Women, rural populations, and minority ethnic groups are more likely to have a vision impairment. But what this study also very interestingly states is that vision loss is both a contributor to inequalities and is also an outcome in inequality. The eye health sector, interestingly, is also lacking behind the broader developmental sector in terms of gender parity, whether it's in terms of leadership, whether it's in terms of the research-oriented work that is happening, and others. The eye health sector is also lagging behind. The problems, as we all know, are many. And with vision being one of our most dominant sensory organ and helping in all facets of our life, visual impairment severely impacts, be it education, workforce participation, mobility, quality of life, mental health. And as all our previous speakers have been speaking about, the barriers to eye care. They are all very well known, be it availability, accessibility, affordability, and also the aspect of acceptability among all the people. We at Mission for Vision have been very fortunate to be working with partners like LV Prasad, partners like Shankara, Coimbatore, and the network hospitals, partners like many others who have been at these forums and have spoken eloquently on many of these subjects. And we've been able to go along with our vision to restore the gift of vision to every visually impaired human being, irrespective of nationality, religion, or socioeconomic condition. And our work across the 21 states of our country spanning 160 plus districts, 39 hospitals, and others, we've been able to reach out to provide services to 50% of or more of our work to the females and to the others. If we talk of some of our activities and what we have done, we've been working with institutions to help build up secondary and tertiary eye care, which is aimed at addressing the barriers around availability, accessibility, and affordability. Because if we are able to bring the services to the people at their doorsteps, not only the men folk, but also the women folk would largely benefit from those services and get those services. Mission Netra is a program that we successfully do and facilitate along with our partners, which aims at providing cataract services. Now, we all know that, and our previous speakers have been talking about the effective cataract surgical coverage. The effective cataract surgical coverage in sub-Saharan Africa, in South Asia, and others have been at times much significantly lower than that of men. However, Mission Netra, through the outreach programs, through our community eye health programs, have been able to undertake screening programs, counsel people at their doorsteps, and ensure that more and more women people are able to get the service. And this, in a way, has been able to improve the equity, which is measured by expenditure, whether it's a caregiver who's freed up of taking care of somebody or herself been getting employed back or been able to contribute meaningfully to the work. Mission Jyot Vision Center program, where we established a network of 103 vision centers in 12 Indian states, and our own work along with our partners like the LV Prasads and all the others have shown that these initiatives have helped provide services to the people. And interestingly, our statistics show that 54% of all the spectacles that were provided were for women. Of all the surgeries that were conducted, 53% were for the women. And our own study has also shown that in vision centers, which are managed entirely by women's staff, the vision technician or the optometrist being women, the health workers being women, 58% of people screened were women. This also talks about how we need to integrate and attune our programs to cater to the needs of the community. One of our research findings has shown that 78.3% of all women in the 51 to 75 age group has failed to get their cataracts operated, as opposed to 67% male in the same age group. 94% women have reported being having identified with a cataract at a vision center or an outreach camp, as opposed to 83% male. And 15% of women have also reported awareness or knowledge as a key barrier for the uptake of services, as opposed to 10% male. Why am I giving these research findings or our experiences? This is all to drive home the need that when we do our programs, be it eye health, hospitals, vision centers, screening camps, school eye health initiatives, and others, we need to keep in mind gender equity. We need to keep in mind the empowerment. We need to keep in mind the inclusion of all people to ensure more and more services. Our school health initiative, which at the moment remains suspended because of the COVID pandemic, has again been able to reach out to 51% girl students across all our locations, and 56% spectacles have been provided to the girl child. An interesting program that we again do, partnering with Shankara and with LVP, is the training of allied ophthalmic personnel, predominantly young ladies and girls from the rural backgrounds, from the rural villages, and from rural areas. And these programs, in addition to addressing and increasing the quality of the eye health cadre, also addresses issues like empowerment, livelihood, soft skills, including negotiation skills, communications, and all others. And these are programs and these are initiatives that bring forth gender equity and helps bring in some parity. I would not be dwelling much on this because all our previous speakers have touched base on this, but it's a very known fact that eye health care has a direct impact on 10 of the 17 SDGs. And eye health care is not standalone. It needs to be part and parcel and needs to include both male, females, and all others as we progress forward. What are the key takeaways that we can talk of? Gender equity should not be an add-on. It needs to be central to the organization or the program's strategic plan. Right from the time when we are conceptualizing a program to when we are implementing it, to monitoring it or evaluating it, gender equity should be at the fore and it should be taken into consideration. Gender equity is also a necessary strategy in the pursuit of universal health coverage. And eye health is integral to advancing sustainable development plan. It is not that we are saying that by gender equity we need to focus more on men. No, we are saying that people should all come together. Men should be equally part of the process as we take forth all our initiatives across locations and across things. I'd just like to end with a nice quote that I read recently from Dr. Jane Goodall, who's a primatologist who's done a lot of work around chimpanzees and others. She had quoted from a Latin American tribe that she had heard, wherein the tribe equate themselves to an eagle, with one wing being male and the other wing being female. And the tribe believes that for the eagle to fly farther and stronger, they need to be equally strong and equally conjoined and functioning together to ensure that the success is there. Thank you.
Thank you, Sabitra, for providing a review about gender equity. And it's really nice that Mission for Vision is taking care that special provisions, services to be given and support to be given to the females. In fact, I was very much concerned. We did National Blindness Survey. Even that survey found that the prevalence of blindness and all type of visual impairment was higher among females. On the other hand, we also know that life expectancy is much higher in females. It is at least 2 years more than the males. That means something is there. So we recalculated about the proportion of cataract surgeries conducted among male and female. And surprisingly, number of surgeries were more among females compared to males. So what I believe is because the life expectancy is high, probably need for cataract surgery is high among females. So even if you provide equal services, number of cataract surgeries, even then you will find more prevalence of blindness or visual impairment among females. Thank you.
One point I want to stress on this point, we should not divide the society into male and female as far as treatment of eye is concerned, because in an academic circle as this gender, we assume that there is no, our society is divided. This kind of attitude should not be encouraged. We are treating male female together. Your presentation may be a focus that we have to focus on female, but saying that equity is not there, they are divided, then it gives a wrong perception. When we talk outside, that it is assumed that our society is not taking care of the ladies.
Sir,
it is the only society where the ladies have been celebrated from the Vedic times, and to tell them that we are discriminating as far as treatment is concerned, it's a wrong thing.
No, sir, there is no discrimination. It is just analysis of data. Since women are not reaching for surgery.
The term is that equity, that they are not equal. That word should be coined in a way that we have to focus on ladies more, because they are contributing to the family welfare more, and the word carries a stigma, that is that the society is discriminating the females, and this is the only society in the world which celebrates women, and we don't want that picture going outside our academic circle talking about discrimination. That point has to be noted. Either you differ that the ladies are discriminated here. Every family that encourages the girl as that whatever happened during the Mughal era and other things, forget about it. Our ethos is that ladies are supreme. So let us not, please don't take it in a different way, because our countries, one moment we all start talking about discrimination, this is another thing they will catch hold. They are waiting there to downgrade us. This is New York Times and other things. This is a society where the female is being troubled and all sort of things. See, these educated people are also talking about discrimination in treatment. Never I've seen that they are our mother and sisters. Let us. This is I'm little bit into this cultural.
I think we should. Thank you, Sabitra. We should invite the next speaker, and Dr. Kaushik Murali. He'll talk about integrated people-centered eye care to achieve universal eye health. Dr. Kaushik is President of Medical Administration, Quality and Education in Sankara Eye Foundation.
Thank you so much, sir. I think grateful to the people who are staying on in the hall for the pretty much the last session of the conference. What I'm going to be sharing is about people-centered care and how you actually go about it. So this is a little creative that talks about what does it mean by being people-centered or in terms of general healthcare. So at the center is the person, he has his immediate family, the community, and we need to see how we can be universal, equitable, people-centered, which includes service delivery. The health sector has to be there, and you need many other sectors, right from education to the sanitation, labor, housing, environment, to enable this kind of a people-centered healthcare when you look at health services. I'm going to be sharing some of our experiences at Shankara, where we've tried to ensure that eye health is not defined by where the person lives. So over the last 4 decades, we've made sure that we've had about 30,000 odd screening camps. We've screened near about 6 million population and done about 2.2 million surgeries to the underprivileged free of cost. So that is one facet of care that we've done by bridging outreach camps, having vision centers, as well as enabling hospital-based services. Like Dr. Rohit mentioned, one of the key highlights of the World Health Assembly in 2020 was the passing of the resolution, which mentioned about integrated people-centered eye care, including preventable vision impairment and blindness. So this requested WHO to develop a guidance on evidence-based, cost-effective eye care intervention and approaches to facilitate the integration of eye health into universal health coverage. Now this sounds very fancy, it sounds very idealistic, but they've actually gone ahead and done a lot on that. What do we mean by integrated people-centered eye care? So to break it down, it is services that are managed and delivered so that people receive a continuum of healthcare intervention. So it's not just a one-off event. It covers promotion, prevention, treatment, and rehabilitation to address the complete spectrum of eye conditions according to their needs, coordinated across different levels and site of care within and beyond the health sector. And what it critically does is it recognizes people as participants as well as beneficiaries of these services throughout their life course. Again, we keep using these fancy terms, quite often not even understanding what we are expected to do as operating doctors or being part of the healthcare system. So what do we mean by integrated? Integrated means it's a package of interventions for a particular group. It includes a range of services that is provided at a location so the person doesn't have to keep going from one place to the other. It includes continuity of care over time, referrals between different systems. So you don't need to do it, but you should know where to refer. And you need to be working across sectors to make sure that there is completeness in it. This again is a creative that was shared as a part of the WHO document, which talks about how you can have a continuity of care right from the community to the secondary and the tertiary care. And it again straddles across from screening, clinical examination, treatment, and rehabilitation. So when you look at this one particular thing, you know that at every level there is a play possible, how eye care could actually be integrated into the existing healthcare system. And that makes our role very, very important as ophthalmologists or eye care professionals or from the non-profit NGOs that are working in various facets of this to enable this to happen. I will draw on our experience of our pediatric program called Nanakandu that we launched in Bangalore, supported by Sightsavers then, which had a very clear philosophy of saying that no child, and we define child as from newborn to 18 years, should be needlessly blind, and those with irreversible blindness or low vision should have the same rights and access to services. At that point in time, honestly, we didn't understand what this meant. Advocacy was a term that was pretty much thrust on us by Elizabeth, who was then the director. So we kept fighting with her saying, what advocacy will we do? Let's go operate and get these children treated. But slowly over a period of time, we've understood how critical that aspect is for us to drive policy and intervention and change. So again, when you look at creating an enabling environment, the first step, Dr. Rohit mentioned about the guide. So there are 4 documents that are available on the IFPB site, which is a pretty much an SOP. You can just go and implement and figure out what has to be done. The 4 key pillars are about empowering, engaging people, reorienting the model of care, strengthening governance and accountability, and coordinating services across within and across the sectors. So again, when we talk, let's look at each one of this. When you talk of empowering and engaging community, you're looking at increasing the demand of eye care, including rehabilitation, encouraging timely and appropriate health-seeking behavior, and increasing access via community-based approaches, telehealth. So COVID has taught us that a lot of things can be done with technology. Again, I draw on what we've done in terms of advocacy, in terms of creating demand. So we've done the walkathons, we've done various advocacy events. We put up the world's largest vision chart on a building that was under construction. So this kind of makes people start discussing about eye health. So not just about looking at it. When you look at the human angle of enabling manpower, again, we've drawn on a tiered system where we use volunteer teachers as screeners. So a 90-minute session allows them to understand how it has to be done. And with a key informant method, this is very, very effective. Reorienting the model puts emphasis on primary care. It facilitates level of care from promotion to rehabilitation, timeliness in diagnosis, and the most critical part that we often forget in large community interventions is we look at quantity over quality. But here monitoring is very critical and affordability and access is again very critical. So again, we've looked at the tiered screening model where we said that, okay, we're using teachers, but are they effective? Again, we found them to be extremely good in picking up. So they had a sensitivity of almost 100%. Specificity was very, very high. And referral rates were also very good. So in any of these, you need to be clear saying that how do you measure effectiveness? And if more than 10% are referred, probably you're overdoing it. If it's less than 40% are being picked up, then maybe the training needs to be relooked at. The third pillar looked at coordinating services, where we said that you need to ensure continuity of care and patient-centered care, coordinate eye health within the healthcare, looking at neonates, non-communicable diseases, and occupational health, reframe it so that it is contributing to the sustainable development goal, and work across sectors and ministries. This again is a little video of how we worked with the corporate to make sure that we are able to deliver this. Again, we've worked with Sarva Siksha Abhiyan. So this kind of puts together a model of us being able to take the clinic to the community.
The entire vehicle comprises of what we use in the hospital. It's a mini OPD. All the facilities that are present in our hospital have been installed inside. The instruments we have, firstly we have a lensometer, which will give us the power of the spectacle already being used by the patient. The second is an autorefractometer to give us an automatic read up or a printout of the patient's refractive error. Then we have a trial lens set consisting of all the possible lens powers which we use for trial and error method. A slit lamp biomicroscope, then a direct ophthalmoscope to see the retina, and the fundus camera which can be captured on an iPhone.
So this kind of is possible today and we can push it out. The last bit is about creating an enabling environment where you enhance it by integrating it in health strategies. I think Vision 2020 and many of the stalwarts here have been doing that and making sure that we get that visibility in terms of the plans that are being done. Then you need regulation, you need to prioritize investment. Again, you look at the health budgets, eye care does not get what it deserves. Despite us having a national program for 30 years, you probably have somebody who's wearing 2 hats and they don't care about eye health, unfortunately. We also need to look at quality control and accreditation and also look at health information. Again, in terms of building manpower, we've had our own academy where we've been training the entire spectrum of students. That kind of becomes very critical when you're looking at developing your own, nurturing your talent. Again, the documents talk of indicators. Again, what I found was this looks largely at cataract and refractive errors. Like Dr. Rohit mentioned, those are the agendas. So these are measures which every institution probably should start recording. And that will help us understand where we are moving the needle in terms of where we should be and where we currently are. My last video is again to reiterate why we do what we do. And, sorry.
ಬೋರ್ಡಲ್ಲಿ ಏನು ಕಾಣಿಸ್ತಾನೆ ಇರಲಿಲ್ಲ ನನಗೆ. ನಾನು ನನ್ನ ಫ್ರೆಂಡ್ ಬುಕ್ನ ನೋಡ್ಕೊಂಡು ಕಾಪಿ ಮಾಡ್ತಾ ಇದ್ದೆ ಸರ್. ಒಂದಿನ ಕ್ಲಾಸಲ್ಲಿ ಟೀಚರು ಕಣ್ಣಿಗೆ ಟೆಸ್ಟ್ ಮಾಡಿಸಿದ್ರು ಸರ್. ಹಿಂಗೆ ಒಂದ್ ಕಣ್ ಮುಚ್ಚಿಬಿಟ್ಟು ಇನ್ನೊಂದ್ ಕಣ್ ತೆಗೆದ್ಬಿಟ್ಟು ನೋಡಕ್ ಹೇಳಿದ್ರು. ಅದ್ರಲ್ಲಿ ನನ್ಗೇನು ಕಾಣಿಸ್ತಾನೆ ಇರ್ಲಿಲ್ಲ. ನಮ್ ಟೀಚರ್ ಹೇಳಿದ್ರು ನನ್ ಕಣ್ಣಲ್ಲಿ ಏನೋ ಪ್ರಾಬ್ಲಮ್ ಇದೆ ಅಂತ. ಇನ್ನೊಂದ್ ದಿವಸ ನಮ್ ಸ್ಕೂಲ್ಗೆ ಶಂಕರ ಹಾಸ್ಪಿಟಲ್ ಇಂದ ಡಾಕ್ಟರ್ಸ್ ಬಂದಿದ್ರು. ಅವರು ಹಿಂಗೆ ಕಣ್ಣಿಗೆಲ್ಲ ಟಾರ್ಚ್ ಬಿಟ್ಟು ಮತ್ತೆ ಅದೇ ಅಕ್ಷರಗಳನ್ನ ಓದಕ್ ಹೇಳಿದ್ರು. ಡಾಕ್ಟರ್ ಹೇಳಿದ್ರು ನನ್ಗೆ ಕನ್ನಡಕ ಕೊಡ್ಲೇಬೇಕು ಅಂತ. ಒಂದು ಬಾಕ್ಸ್ ಅಲ್ಲಿ ಫುಲ್ಲು ಕನ್ನಡಕ ತೋರ್ಸಿದ್ರು. ಇದ್ರಲ್ಲಿ ಯಾವ್ದ್ ಬೇಕಾದ್ರೂ ತಗೋ ಅಂತ ಹೇಳಿದ್ರು. ನನಗೆ ಈ ಕಲರ್ ಇಷ್ಟ ಆಯ್ತು, ಅದಕ್ಕೆ ನಾನು ಇದೇ ತಗೊಂಡ್ಬಿಟ್ಟೆ. ಕನ್ನಡಕ ಹಾಕ್ದಾಗಿಂದ ಬೋರ್ಡ್ ಅಲ್ಲಿರೋ ಅಕ್ಷರಗಳೆಲ್ಲ ಫುಲ್ ಕ್ಲಿಯರ್ ಆಗಿ ಕಾಣಿಸ. ಈಗ ಕ್ಲಾಸಲ್ಲಿ ನಾನು ಎಲ್ ಬೇಕಾದ್ರೂ ಕೂತ್ಕೋಬಹುದು. ನನ್ನ ಹೆಸರು ನಂದಿನಿ. ನಾನು ಚಾಮರಾಜನಗರದ ಗವರ್ಮೆಂಟ್ ಸ್ಕೂಲ್ನಲ್ಲಿ ಓದ್ತಾ ಇದ್ದೀನಿ.
So I think it is very important for us to remember why we are here and what we do and keep at it, because end of the day we want every Indian to see the rainbow. Thank you so much.
Thank you, Kaushik. In fact, you have highlighted the IPC and also you are able to show it very clearly how Shankara Eye Foundation able to integrate this into their model. Thank you very much. In fact, we were able to getting it over timely because we had a timer for 8 minutes for a 13-minute presentation, so all of us finished timely. Now I request Phanendra Babu, is CEO of Vision 22 Right to Sight, to give a concluding remarks. You have 5 to 7 minutes to give in details. Thank you.
Great, thank you. So this is the last session of the entire conference and the last day and the last speaker I am today. So thank you. So on behalf of Vision 2020 India, I want to thank Chair, Vice Chair and Moderator for very nicely conducting this session. As I don't have any presentation. And thanks to the speakers for bringing their experiences and highlighting some of their perspectives from their experiences from their projects. And also, dear audience, thank you so much for taking your time and really attending this session to the last day and the last minute of the today's conference. So thank you so much once again on behalf of Vision 2020 India. So I was actually noting some of the points from this session. So issues that we have noted, a quick summary of it from the last for the 5-6 presentations. We have issues still around the availability, accessibility, and affordability of eye care. And also, I'm really surprised to note that 8 countries out of 24 countries do not recognize optometry as a profession currently, even as on date. So if this is the situation about optometry, you can actually imagine the situation about inclusive eye health that we have been talking about for the last one and a half hours. And we also, I think, agreed that integration, we need to have a clarity. What do we mean by integration in our approaches? And some of the barriers of accessing to eye care services, particularly for the people with the disabilities. And good that we have some other some of examples that we have seen from CBM experiences and the Perkins India's experience of providing eye care to the people with the disabilities. I also like the one point. There's one video from Dr. Harpreet's presentation. There's some gentleman. People with the disabilities have some other abilities. I think that's very important to note that I have, taken home back. I think this is a very important point that all of us need to keep this in mind. And we also understood that there are sporadic attempts, but I think we need a long-term impact. As a panel really pointed out, and we need the support of bodies like AIOS to take this agenda forward, in addition to other bodies like Vision 2020 India. And we also agreed that we need the collective evidence-based policies, evidence-based advocacy to take this agenda forward. And also there's no the disability segregated data is not available in the country. And so Dr. Praveen actually presented with a lot of question marks. There's no data about the disability segregated data for any of the indicators. And also we took a note that the inclusion is a word that is not there in national policies, including some of the strategic plans of our major development agencies. And then there is a national task force for inclusive eye health that is coming up. I think that will pave the way for addressing some of the issues that we are talking about here through a policy approach at the national level. And so a great learning experience from Perkins India's Inclusive Eye Care Services. I think pictures spoke a lot. Thanks to Sampada. Thank you so much for really making very picture-oriented, and really pictures spoke a lot. And the gender gap, we had a very good discussion. Thanks to the panel, sir, Dr. Sahu and Dr. Praveen, really pointing out on some of the issues about gender. And we have heard from the Mission for Vision presentation, a gender gap in receiving eye care, a lot of gender gap issues. And gender equity should not be an add-on, but it needs to be central to the organization, is the key takeaway from the presentation of Sabitra. And finally, that we have Sankara experience now with integrated people-centered eye care. I've been really Sankara's experience. I've been, throughout the Karnataka, I've been providing in terms of the eye care. So this is what the quick learnings of today's presentation, today's session. And once again, I would like to thank all the chair, co-chair, and moderator, speakers, and all the audience for really making it possible today and making this a successful event. Thank you so much.
Thank you.